James.
Yeah, you bet. Well, good morning, and it is really a pleasure to be able to present to you all today. Like Len said, my name is James Song. I run our clinical trials center and our inflammatory disease clinic based in Mill Creek, Washington at Frontier Dermatology. And there hasn't probably been a class of medication that we as dermatologists have been as excited about as the JAK inhibitors. And a lot of that comes from the fact that we had so many what we call orphan diseases where there's not a single FDA approved treatment, where the JAK inhibitors not only work, but they worked incredibly well. And that's because a lot of the cytokines that are driving the inflammatory diseases that we're treating do signal through JAKs, that pathway. But not even just for those orphan diseases, in diseases that we treat all the time that already have established FDA treatments like atopic dermatitis, for example, we are still seeing, I would say, quite a bit more of an improvement than what we would consider to be a standard of care. And we're seeing a level and depth of response, whether it's itch reduction or skin clearance with our JAK inhibitors, that we really have not seen with any of our prior therapies, including our monoclonal antibodies. However, a lot of that excitement has been tempered by this black box warning that was, I would say, gifted to the JAK inhibitors coming from a dedicated safety study looking at a completely different patient population using a completely different JAK inhibitor. And the FDA decided to kind of give the same box warning to all the JAK inhibitors, including the ones that we use in dermatology. And as such, as Len kind of alluded to this, a lot of our healthcare providers have had some hesitancy to use these medications because of that box warning. And that unfortunately has led to a lot of underutilization. And I would quite frankly say our patients are probably just suffering with their diseases when they have the potential to get even a better response. And so what I want to do today, hopefully, is not just speak to the efficacy and why we should consider using JAK inhibitors, but also to help kind of contextualize the safety data so that you as practitioners can really have a much more informed consent or decision making rather than just saying, hey, read the box warning and let me know if you want the medication. So with that, we'll get started. These are my disclosures, and I highlighted the 5 that are relevant because I am either a consultant, a promotional speaker, or an investigator for the products that we will be talking about today. So the goals for today is to first review efficacy of the JAK inhibitors, and we want to compare it to our kind of standard of care, whether that's biologics or a traditional systemic immunosuppressants, and then appraise safety data for the JAK inhibitors and discuss what this actually means in the context of not rheumatoid arthritis, not inflammatory bowel disease, but atopic dermatitis. That's the disease that we're treating. And then finally discuss what are some best practices to reduce those risks and improve patient adherence with JAK inhibitor usage. It's pretty incredible to see how far we've come in treating atopic dermatitis. I mean, you think even pre-2017, which wasn't that long ago, we did not have a single FDA-approved medication for moderate to severe AD, with the exception of prednisone, which, of course, as you know, got grandfathered, and it did not go through the same rigorous phase 3 studies like all of our current therapies have. But that's in part because our understanding of atopic dermatitis has advanced so much. Right. And back in the day, we did know that, yes, there's inflammation, there's edema, and there's some swelling in the skin. And on the left-hand side, this is just a histopathology of a patient with atopic dermatitis, showing those classic changes of spongiosis and that perivascular lymphocytic infiltrate, which are all those blue dots in the papillary dermis. But that was pretty much it. We really didn't understand AD all that well, which is why we're just throwing a lot of immunosuppressants at our patients with AD. But our understanding, especially at the immunological level, has advanced so much now that we understand, yes, it's inflammation, but it's not just inflammation. There are certain arms of the immune system that are overactivated, particularly Th2, but also, of course, Th22, as well as some contributions from other immune pathways as well, which causes then skin barrier disruption. We can also see a component of the microbiota that's contributing to this as well. So it's much more nuanced than we certainly appreciated from the very beginning. And what that has allowed us to do then is to look at certain cytokines that are driving the disease and then develop therapies that target those cytokines in an attempt to treat atopic dermatitis. But what we learned pretty quickly is that not all cytokines, at least independently, are enough to drive the disease. And we say that because we've done a number of phase 2 or phase 3 studies looking at some of these candidate cytokines, and it didn't really show to be any better than placebo, actually, for some of these cytokines, which is what led to the temporary interruption of the studies. But for the cytokines that have made it to the finish line and that have shown that, yes, blocking one or two of these cytokines could actually improve atopic dermatitis in a meaningful way are the ones that I highlighted here. IL-4 and 13, which, as you know, is being targeted by dupilumab. We have other IL-13 inhibitors, and we have a novel IL-31 inhibitor that's in phase 3, that just finished phase 3, excuse me, and that's already filing to the FDA for an atopic dermatitis indication. So this is probably the group right here that we're focusing the most on. But let's go with dupilumab first, because this is, as you know, the first biologic that was approved for AD. In many ways, this is a landmark drug because it really changed the paradigm of how we treat patients. This is coming from their website, actually, and we're looking at the rates of getting people to completely clear or almost clear, right? That's the IGA. That's our standard endpoint in an atopic dermatitis trial. And admittedly, it's a very stringent endpoint. But that said, you're seeing that about a third of patients are getting to clear or almost clear with dupilumab, and that's even if you're combining it with a mid-potency topical corticosteroid, okay? Which means that roughly 2/3 of patients are still not getting to clear or almost clear. And just to use an analogy here, in psoriasis, which I know that you're not really treating primarily, we can get patients to clear or almost clear well over 80 to maybe even close to 90% of the time. And that's with monotherapy, right? And that's really because we understand psoriasis so well, and we have therapies that are so targeted. But in atopic dermatitis, we are not there yet, right? And so there's certainly room to improve. And one of the reasons why monoclonal antibodies may not be enough for some, if not many, of our atopic dermatitis patients is because it's not as homogeneous as some disorders like psoriasis. It's actually a much more heterogeneous group of patients. And this was proven kind of by a proof of concept by Emma Gutman's lab at Mount Sinai, where they use this kind of novel tape stripping test where they will literally just apply a test to the atopic dermatitis lesion, perform a number of different studies, and they could really understand the immunological profile for each of these patients. And what became clear is that, yes, for all of these patients, there is a Th2 skewing. It didn't matter whether you're European, Asian, Black, or a pediatric onset. But in addition to that Th2 skewing, what did become clear is that there are other parts of the immune system that are overactive or underactive depending on the type of patient that we're looking at. For example, if you look at a European American patient, you're going to have primarily Th2 and Th22. That's very common. But if you look at Asian patients, you also had Th17 overexpression too. That's a psoriasis signature. And so in many Asian patients, you have sometimes more looks like eczema, but you also have concomitant psoriasiform type of lesions. Whereas in Black patients, you did not have any Th17 or any Th1, primarily Th2. And you can see with pediatric patients, look kind of more like our Asian patients as well. The point here is that we have so many different immune axes that are overexpressed in our atopic dermatitis patients that maybe we are too selective with our biologics. And here we're just showing you 6 different cytokines that have been implicated in atopic dermatitis. Certainly there are more, but our current therapies are blocking maybe 1 or 2 of these cytokines, and I'm just showing them to you here. But as it just showed you, we have contributions from various other cytokines in addition to these IL-4, 13, and 31. And so maybe we need to get a little bit broader in the cytokines that we're inhibiting. And the way that we can do that is by going after the JAK-STAT pathway, because all of these cytokines, the one thing they have in common is that they require JAK-STAT to signal their message from the outside to the inside, which ultimately leads to gene transcription of pro-inflammatory cytokines. And as you can see here, we have a number of different JAK inhibitors that are going to be targeting various different pairs of JAK enzymes. But it's really just trying to figure out which JAK enzymes we should be inhibiting so that we could be treating a particular disease, in this case, atopic dermatitis. And so here's the good and the bad with JAK inhibition. The good is that by targeting a single JAK enzyme or a pair of JAK enzymes, we could inhibit a broad range of cytokines, right? And if you look on the left here, if you just block JAK1, okay, you're seeing that these cytokines are primarily the ones that are implicated in atopic dermatitis. And so you want to go after JAK1. But if you start to get a little bit broader and start inhibiting, let's say, JAK2 or JAK3, you're starting to see a little bit of a kind of a spillover effect, and that you're getting some collateral damage now, because now you're inhibiting erythropoietin, thrombopoietin, GM-CSF, right? And that could potentially cause cytopenias, amongst other kind of adverse events. And so in the perfect world, we want to be very selective in what we inhibit, right? And we want to be able to kind of change it based on what we're trying to treat, right? Because certain diseases have other cytokines that are signaling through different JAK enzymes, and those are the ones that we're going to be targeting. So I kind of mentioned this already, but why be selective? Well, we know there's a broad range of interleukins, interferons, cytokines that are JAK-STAT dependent, and those biological functions are affected by JAK-STAT inhibition. So some JAK enzymes are important for growth and differentiation, metabolism, anti-tumor viral defense, and of course, immunoregulation. Most of our side effects, though, they can be explained by the cytokines that are inhibited. And it's important to note that we have two general classes of JAK inhibitors. The first generation JAK inhibitors, often referred to as pan-JAK, because they inhibit a broad range of cytokines, over 50 of them. And these are the two typical examples, tofacitinib and baricitinib. And we also have kind of these second generation, or kind of these selective JAK inhibitors that affect a fewer range of cytokines. And as such, they are potentially more efficacious with a potentially better safety profile. And these are the two ones here, abrocitinib and upadacitinib, which are both approved for atopic dermatitis. And here's just a proof that not all JAK inhibitors are the same. We are looking at the selectivity for these different JAK enzymes in a test tube, right? And the way we measure selectivity is the IC50. So the lower the IC50, the more selective a JAK inhibitor is for a particular JAK enzyme. And as you can see here, abrocitinib and upadacitinib, very, very selective for JAK1, much less selective for JAK2, JAK3, and TYK2. So we refer to these kind of as our second generation JAK inhibitors. When you compare that to baricitinib, which is a first generation JAK inhibitor, we're seeing that we have equal, for the most part, selectivity both for JAK1 and JAK2, much less for JAK3 and TYK2. So that's considered more of a pan-JAK inhibitor. That said, really, we don't have a JAK inhibitor that's truly 100% selective, because what ends up happening is that if you use a low dose of a JAK inhibitor and you study it in a test tube, yes, it could look very selective. But when you start ramping that dose up to higher doses to get better efficacy, you do start to lose some of that selectivity as well. And that is why with some of our JAK inhibitors, when you go to the higher doses, you are starting to see more adverse events. So there's something to be aware of. Now I'm just going to show a couple of my own patients that I've treated with JAK inhibitors. These patients pretty much have failed every single conventional and unconventional therapy for atopic dermatitis. And as soon as we got the JAK inhibitors approved, we had a ton of patients that went on it right away. And let me just say, what a ride it's been. Truly just seeing how these medications have changed these patients' lives. I mean, this is a patient, my first adolescent patient that actually went on a JAK inhibitor. And she was on dupilumab for years. We had to add cyclosporin, methotrexate, phototherapy. We patch tested her as well, and just a tremendous burden on her life. I mean, she got made fun of at school. She missed school a ton. She would always kind of sit in the back of the room with the hoodie on so that she could cover her face. But this is 12 weeks of upadacitinib at 15 milligrams daily. And this patient, like many of my patients, have said, I felt better within the first day of taking the medication. Obviously, same patient, but just a different side of her face, and just, really incredible results. This is another patient. She was one of my earlier patients as well. She was an esthetician, and she was on dupilumab, and everything else cleared up pretty well, but she just had this persistent kind of involvement of the head and neck. She did have quite a few relevant contact allergens, but unfortunately, she could not avoid it based on her line of work as an esthetician. So she had a fragrance, balsam of Peru, a nickel, and a limonene allergy, and we could not clear her despite what we threw at her. And this is 12 weeks of upadacitinib as well. This is an elderly patient that had pretty much every single risk factor for MACE and VTE. So she was hypertensive, she smoked, she had a prior history of a VTE before, hyperlipidemic, and she had more of this kind of prurigo type of AD, primarily on the legs. And she was quite frankly suicidal. She said that if we can't get her better, she's going to jump off a building. I mean, that's how miserable she was. And as you can imagine, this patient has tried every single thing as well. Dupilumab, tralokinumab, multiple courses of systemic steroids, I probably caused her kidneys to get shot because I gave her tons of cyclosporin and methotrexate, but we didn't really have that many options. And this is a patient also on upadacitinib. Okay, and this is literally her 4-week follow-up because she was because I was quite frankly a little nervous based on her risk profile, but I mean you can just see these incredible results. And lastly, this is a patient that was a high school 3-sport athlete, and he was actually getting scouted for colleges to play basketball and football. So very, very talented kid here, but he had to actually miss his senior year of high school because his atopic dermatitis was so bad, and he unfortunately was not able to continue with his scholastic and his sports scholarship, excuse me, because of his atopic dermatitis. And he came to me kind of out of desperation after having tried multiple different agents, including dupilumab and tralokinumab. And this is a patient on abrocitinib. So this is the other JAK inhibitor, and you can see at 12 weeks, really just kind of tremendous results, right? These are patients who've tried our first-line agents for atopic dermatitis, did not respond, but still getting this level of response. So how do our JAK inhibitors fare against dupilumab, which many people would consider to be the first-line therapy for moderate to severe atopic dermatitis? And I'm not arguing that because it is a wonderful medication, don't get me wrong. But we have a couple of studies that we're going to show you that are head-to-head between dupilumab and our JAK inhibitors. This one here actually isn't a true head-to-head study. This is actually called the JADE Compare study. This is one of the pivotal studies that led to the approval of abrocitinib for atopic dermatitis. But there was a dupilumab arm here to serve more as an active control. So if you look on the left-hand side, this is clear or almost clear. That's a stringent endpoint. The orange and the blue lines, those are the 2 different doses of abrocitinib, and you're clearly seeing that the higher doses of abro works better. We're seeing just under 50% of patients getting to that stringent endpoint, and that light green line is the dupilumab control arm as well. So what you're seeing here is that both doses of abrocitinib, they work actually much more quickly than dupilumab. You see that separation happening in early as 2 weeks. And with time, you do see that dupilumab does catch up to the lower dose of abrocitinib. But when you look at the higher dose of abrocitinib, you clearly see that numerically this was better, although this was not considered to be a head-to-head study. This is a head-to-head study. We're looking at dupilumab versus upadacitinib at the 30 milligram dose. So that's the higher dose of upadacitinib. That's not the FDA-approved starting dose, but you could switch to 30 milligrams pretty quickly after the first couple of weeks. And when you're looking at EASI-90 now, that's a more stringent endpoint than EASI-75. You're clearly seeing superiority with upadacitinib versus dupilumab. So upadacitinib in blue, right? And you see again that quick separation right out of the gate. And that's EASI-90 in the left. When you look at worst itch reduction, so this is the peak pruritus NRS. This is a scale from 0 to 10. You can see how quickly the itch goes down, right? Within days, we're talking about, you're starting to see that with upadacitinib, clearly superior to dupilumab, even at 16 weeks. And this is a head-to-head study with dupilumab and abrocitinib. This is also at the higher doses, followed the 200 milligrams. On the left-hand side, we're looking at patients who failed at least one systemic therapy. And on the right-hand side, these are patients who have been naive to prior systemic AD therapy. And what you're seeing here is that at EASI-75, both drugs performed well. Numerically, it was higher with abrocitinib, but they still performed fairly well. But when you look at the more stringent endpoints like EASI-90, EASI-100, or a peak pruritus NRS of 0.1, meaning you have no itch or trace itch, which is a very difficult thing to do, that's really when you start to see separation between our JAK inhibitors and dupilumab. We also see a bigger difference when you're looking at speed of onset. That's really where the JAK inhibitors have the advantage over dupilumab as well. But the bottom line here is that when you look at EASI-75, all drugs work actually fairly well. When you look at EASI-90, EASI-100, or NRS 0.1, that's really when you start to see the JAK inhibitors doing better than our biologics. Now, you may say, well, dupilumab seems to do pretty well from an EASI-75 standpoint. Isn't that enough? And I would say it depends, right? So this is looking at a post-hoc analysis from the upadacitinib pivotal studies. And what we're looking at here are the percentage of patients who achieved what we consider to be an ideal state from various different patient-reported outcomes. So I'm showing you 6 of them here: Dermatology Life Quality Index, the POEM score, skin pain, sleep scores, activities of daily living, and their emotional state. And it shouldn't be a surprise that as your skin clears more, you have a higher likelihood of achieving that ideal state in one of these 6 patient-reported outcomes. But what was a surprise is that if you look at the dark blue bar, that's the EASI 90 responders, and you compare it to the bar to the right, that's the lighter blue bar, that's the EASI 75 responders. Even though on paper, EASI 75 and EASI 90 may not seem like that much of a difference, right? Just a few percentage points, we're seeing an exponential difference when it comes to the likelihood of getting to an ideal state in your quality of life. And if you want to raise the bar even higher, and you're looking at people who are EASI 90 at least, and then we're also overlaying on top of that patients who had no itch or trace itch. That's what an NRS01 means. Look at this. I mean, these patients were much, much more likely to get to that ideal state when it comes from a quality of life standpoint versus patients who had maybe a little itch, which is an NRS of 2 or 3. So the point here is that if you want to give our patients the best quality of life where their atopic dermatitis has no or little impact on them, we should be looking at more stringent endpoints and not just settling for EASI 75. Now, another question that comes up, and this may be actually a more clinically relevant question because many of you are using dupilumab as first line, which there's nothing wrong with that. It's a wonderful medication. But it's to know what happens if you're on dupilumab and you don't get to a certain level of response. If I switch you to maybe one of these two JAK inhibitors, what's the likelihood that those patients will do better? And this is one of those studies that I'm going to talk about. This is the JADE Extend study, where we took those 242 patients that were on dupilumab in the JADE Compare study that I just showed you, and then we switched them to either 1 or 2 different doses of abrocitinib, 1 or 200 milligrams. And what you're looking at here are patients who were on dupilumab for 16 weeks, and they did not get to a certain level of response, whether that's an IGA 0/1, EASI 75, EASI 90, or a NRS of 0/1. And what I boxed here is the EASI 75. If you didn't get EASI 75 with dupilumab, when we switched you to abrocitinib 100 milligrams, we saw that 68% of patients still got EASI 75. And then if you went to the higher dose of 200 milligrams, 80% of patients now were able to get to EASI 75. So what I tell patients is roughly 70 to 80% of you will get a good response with dupilumab, with abrocitinib, even if you didn't get that with dupilumab. And this is the head-to-head study that I showed you earlier between dupilumab and upadacitinib. And I showed you the data already for the first 24 weeks. But now what I'm showing you is what happens after 24 weeks when those patients who are on dupilumab, which is that purple line, get switched over to upadacitinib. And you can see that these patients do significantly better, especially at the more stringent endpoints of EASI 90 and EASI 100. So I showed you a lot of data between JAK inhibitors and dupilumab, but how do they do compared to some of our other therapies in atopic dermatitis? And so this is a recent systematic review and network meta-analysis comparing all of our FDA and EMA approved drugs for atopic dermatitis and comparing that to dupilumab. And if you look at EASI scores, which is on the top half, you're seeing that both abrocitinib and upadacitinib at the higher doses do compare actually, or they actually do look better than dupilumab. And you can see the confidence intervals do not cross 1 here. And when you look at the itch reduction score, kind of the same story. We're seeing that with the higher doses of abrocitinib and upadacitinib, it does seem to do better than dupilumab, even though the confidence interval does cross 1 here with abrocitinib. Whereas all the other therapies, whether it's baricitinib, which is another JAK inhibitor not approved in the US, it is approved in the ex-US, and tralokinumab don't seem to do quite as well as dupilumab. This is another recent systematic review, just looking at how our JAK inhibitors do compared to our other therapies. And if you look on the left-hand side, the x-axis is a percentage of patients getting to clear or almost clear. And on the y-axis, we're looking at patients getting a 4-grade reduction on that 11-point itch scale. And what you want to see is the higher up and to the further to the right that the dot is, the better it does. And you're seeing that both upadacitinib 30 and abrocitinib 200 really seem to be doing the best from a skin clearance and itch reduction standpoint compared to all the other therapies. And this is just a little bit of a tangent, but one of the advantages of using JAK inhibitors is the fact that it's a small molecule, it works intracellularly, so we don't necessarily have to worry as much about developing neutralizing antibodies. And so, if a patient wanted to start and stop the therapy with an oral JAK inhibitor, I don't worry as much. And this is a study looking at what happens if we get patients to completely clear with abrocitinib 200 milligrams through 12 weeks, and then we either keep you on abrocitinib at 200 milligrams, we drop you to 100 milligrams, or we just take you off of it completely, right? That's the withdrawal arm. And on the left-hand side, what you are looking at is the percentage of patients that flared at different time points. And not a surprise, people who stayed on the 200 milligram dose of abrocitinib, that's kind of the yellow-orange line, they did the best. Less than 1 in 5 had a flare. But if you look at the gray line, that's the people who came off the drug completely. The average time it took for someone to flare was about 30 days, but we still had about 1 in 5 patients at the 281-day mark off the drug where they didn't flare. And if you look on the right-hand side, if you did flare and we put you back on abrocitinib, you can see that gray line. Pretty much almost every single patient recaptured their efficacy in just a short amount of time. So that is maybe a potential benefit for this class as well. Now, we recently had updated guidelines in the treatment of atopic dermatitis. And on the left, this is coming from our society, the American Academy of Dermatology. And on the right, that's going to be your society. And for, at least from a dermatologist perspective, the JAK inhibitors got the same strength of recommendation, so strong recommendation based on a moderate quality of evidence as the monoclonal antibody. So they're on parity with dupilumab and tralokinumab, versus from the Quad AI and the American College of Allergy, Asthma, and Immunology, it actually got downgraded. So it's a conditional in favor of using JAK inhibitors with low certainty evidence. So this is considered to be less favorable of a recommendation compared to our monoclonal antibodies. And so why is that the case? And if you look at this systematic review that was done by the Department of Allergy, okay, what they concluded was that yes, upadacitinib and abrocitinib, they seem to be the most effective, but they're also potentially the most harmful. And they said that risk considerations should include both observed safety data for the individual drugs from clinical trials of patients. We're talking about abrocitinib and upadacitinib, but also class-wide theoretical safety concerns and box warnings, which we'll talk about, but that's coming from a rheumatoid arthritis population with a different JAK inhibitor. And so essentially what the discrepancy here is that due to the lack of long-term safety data with our JAK inhibitors, not the RA JAK inhibitors, but our JAK inhibitors in our patient population, the strength of recommendation is not quite as strong as is coming from the dermatology recommendations. But in that same study, they also quote that we found that the included randomized trials seldom encountered serious adverse events such as death, cancer, or thromboses. And of note, abrocitinib and upadacitinib, the two that we've been talking about, are more selective than tofacitinib. And also they quoted, rheumatoid arthritis patients have a substantially higher cardiovascular risk compared with the general population. And then this oral surveillance trial, which we'll talk about, compared tofacitinib with TNF inhibitors, which are previously shown to reduce cardiovascular disease. So in other words, it's not maybe a fair comparison to look at reducing cardiovascular disease with TNF inhibitors because they've been actually shown to be beneficial in reducing those risks. So as I mentioned, a lot of that excitement with the JAK inhibitors was kind of tempered in 2019 when the FDA gave a new box warning to pretty much all of our JAK inhibitors. And just from a safety standpoint, we talked about the fact that you could predict the safety based on the cytokines that it blocks. And you can see here that these different JAK pairs are responsible for various different biologic functions. And depending on which JAK pair you inhibit, you could probably predict which ones are going to cause cytopenia, which ones will raise your lipids, which ones could theoretically increase your risk of clotting, cancers, and infections. So the JAK inhibitors, they have a box warning. But many of the medications that we use every day also have a box warning as well. And I'm just giving you an example of one of them, right? This box warning is talking about an increased risk of cardiovascular events, including heart attacks and strokes. It also talks about gastric ulcers as well as kidney failure. And this is ibuprofen, right? This is a medicine that we use all the time, right? But we understand the context and the story behind here, and we can explain it to patients in a way where it makes them feel comfortable. But when you look at the box warning for our JAK inhibitors, I think this causes a lot of apprehension because many of us aren't as familiar with where this box warning is coming from, what the story is, and how to explain it to patients in such a way where they feel comfortable making truly an informed decision. So the box warning for our JAKs says serious infections, deaths, major adverse cardiac events, thromboses, and cancers have been reported in people who've taken this medication. And it makes a mention of comparing this to another agent, TNF blockers, in a rheumatoid arthritis population. So there's a little bit of confusion of where that's coming from. So let's unpack this a little bit. Oral surveillance. This was a landmark safety study that looked at the safety of JAK inhibitors versus a biologic in a high-risk rheumatoid arthritis population. And the story is that the first JAK that got approved in the US was tofacitinib. This is a pan-JAK that's approved for rheumatoid arthritis. And early on in the development of this drug, the FDA did note some safety concerns. So they wanted the sponsoring company, Pfizer, to do a dedicated safety study, looking at those particular safety concerns. And they wanted to compare it to the TNF class, because TNF inhibitors are considered to be the first-line therapy for rheumatoid arthritis. But the problem is that those safety things, they were so rare, they happen, in less than 1 in 100, that if we were to study this in just a general rheumatoid arthritis population, we probably would have to do this study for decades because this was an event-driven safety study. So in order for us to be able to detect a signal, we had to look at a higher risk patient population. We had to enrich the population so that these things were more likely to happen. So you had to have moderate to severe RA, which in and of itself is actually a risk factor for every single one of those things we just talked about from the box warning. You had to be over 50. Okay. You had to have at least one cardiovascular risk factor. Every single patient was on methotrexate, and just under 60% were on a glucocorticoid, so essentially systemic steroids. And we looked at the JAK at 2 different doses versus the TNF inhibitors. And the co-primary endpoints here was a non-inferiority of tofacitinib versus the TNF inhibitors when it came to MACE events and cancers. This is just showing you what these patients look like in the study. We're talking about half of these patients who are smokers. About 2/3 of these patients were hypertensive. Just under 1 in 5 had diabetes. We had 19 patients who had a history of a clot, and so on and so forth. So these are really high-risk patients, right? Not the type of patients that we're typically treating in a dermatology or an allergy office. So this was the first endpoint. This is the risk of MACE events, looking at JAK versus TNF inhibition. You can see where I boxed in red. When you combine both doses of tofacitinib and compared it to TNF, we did see a higher incidence rate. So 1.33 was a hazard ratio, but notice the confidence intervals do cross 1. So this is not significant. And on the bottom half, if you were to contextualize that, the number needed to harm, how many patients would you have to put on a JAK inhibitor over a TNF inhibitor, was in the hundreds. The other endpoint was cancer, and we're excluding non-melanoma skin cancers now. And you do see that the hazard ratio, again, was higher, 1.48, and the confidence intervals do not cross 1 now. So we can say this is significant. And we'll talk a little bit more about what type of cancer we're talking about. But again, the number needed to harm, 276 over 276 patients you would have to treat with a JAK inhibitor over a TNF before you got an additional cancer event. What I boxed and underlined in red is all the new language that was updated to the JAK inhibitor class because of that study that we just talked about. And as you'll see this mentioning over and over again, in an RA patient-treated population with another JAK inhibitor, a higher rate of cancers, higher rates of MACE events were reported. And that's where this is coming from. So you'll see the same language even in the ones that we're using in dermatology. So what I want to do now is actually talk about what did oral surveillance actually show, what's the data in atopic dermatitis, and how can we mitigate risk for these adverse events. So let's start with major adverse cardiovascular events. These things actually happen quite rarely in these studies. Get less than 10 out of every 100 patient years with both the JAK and the TNF. Numerically, it was a little bit higher with the JAK than the TNF. But maybe that's not a fair comparison because I kind of mentioned this already. We now have very compelling data, both from observational studies as well as actually randomized controlled studies, to show that using certain biologics can independently lower the risk of cardiovascular disease, even if you don't do anything else for controlling for some of their traditional risk factors, like their lipids, like their blood pressure, right? And we actually have very, very kind of intricate studies now coming from the NIH showing that if you scan these patients with a PET-CT scan, look at inflammatory markers, TNFs in particular really do seem to lower the risk of those events. So perhaps TNF inhibitors are just better than JAK inhibitors at reducing MACE events. And it's not so much that the JAK inhibitors are causing these MACE events, right? Because these studies were not JAK versus placebo, it was JAK versus TNF. And we got some real world studies to show that this may not be the case. So this is coming from a Harvard database of RA patients. I mean, a huge US claims data. We're talking over 100,000 patients. You see anywhere from 9 to 13% of them were on tofacitinib, and the rest were on TNF inhibitors. And if you look on the top half, this is looking at a real-world cohort of patients looking at the rate of MACE events. And we're seeing that the hazard ratio was 1.01. Clearly, that confidence interval crosses 1, so this is not significant. But if you were to replicate a cohort that looked like the oral surveillance patient population, right, so high risk, even with that, we're seeing the pooled hazard ratio, it does not cross 1. This is not significant. And this is also repeated by our German colleagues. This is a rabbit registry, which is one of the largest inflammatory disease registries that we have in the world. And kind of the same story here is that if you were to replicate the oral surveillance cohort in a real world database, and you compare JAK inhibitors versus TNF inhibitors and conventional DMARDs like methotrexate, for example, the risk was very much comparable to both classes. You see those confidence intervals kind of all crossing each other. And so this did give us a little bit more comfort in knowing that at least in the real world, we're not seeing the same type of signal that we saw from oral surveillance. And what about atopic dermatitis? We're seeing extremely low rates, right? On the top half, this is up to 3 years worth of data from upadacitinib. On the bottom in yellow, that's abrocitinib for 2 years. We're seeing rates less than 1 out of every 1,000 patient year or every 100 patient years, meaning I would have to treat 1,000 patients on one of these JAK inhibitors over a year, and one of these MACE events would actually happen. Now, of course, to reduce the risk of MACE, common sense tells us we should be trying our best to control for traditional cardiovascular risk factors, meaning trying to encourage your patients to stop smoking and get your lipids, your weight, your blood pressure, and diabetes under control. But these in and of themselves should not be a contraindication to go on a JAK inhibitor. And I'm actually going to show you some of the data of what those patients look like in the atopic dermatitis trials. And really, these were not your kind of your 18-year-old healthy Olympians that we were recruiting. We were kind of taking all comers for. Now, when you're looking at infection risk with the JAK inhibitors, we actually have quite a few head-to-head studies, not in dermatology, but in rheumatoid arthritis, inflammatory bowel disease, et cetera. And overall, the infection risks seem to be comparable to the biologics when you look at serious and opportunistic infections, but the exception is viral infections. We do see a signal for herpes and shingles infections. So these are things that we want to be aware of and counseling our patients. And it makes sense because we know that interferon alpha and beta is important for antiviral defense. And with our JAK inhibitors, even our selective JAK inhibitors like abrocitinib and upadacitinib, we are still getting some of that JAK1 TYK2 blockage, whereas with dupilumab and tralokinumab, you are not inhibiting that. So this is coming from that same German rabbit registry, looking at an RA population, comparing the risk of shingles across different MOAs. And what becomes clear here is that the JAK inhibitor group had the highest risk of shingles, right? Quite a bit higher than any other class. And on the right-hand side, when you try to look at risk factors, what type of patients are developing shingles? It's if you were a female, the older you were, if you were on concomitant systemic steroids, and if you got JAK inhibitors. Those really seem to be the risk. Now, when you look at the risk of shingles in the dermatology population, this is looking at baricitinib. This is approved for alopecia areata. We're seeing extremely low rates. We're seeing less than 1% in the Brave AA1 trial and just a touch over 1% in the Brave AA2 trials. And this is looking at upadacitinib and abrocitinib. And we're seeing rates anywhere from maybe 3 to 5 out of every 100 patient year. So there is a dose response here, right? The higher doses do seem to increase the risk overall. But the majority of these patients were actually not vaccinated. So we don't actually know what would have happened if these patients were vaccinated before going into the trials. Now, speaking of vaccination, it is something that I talk to my patients about. I don't require it necessarily, although I would say the older the patient gets, right, the more I'm going to probably push them to get the shingles vaccine. Now, you don't necessarily have to wait to get both doses of the shingles vaccine before you start a JAK inhibitor, right? We don't want our patients to have to suffer for a couple months. In fact, most of my patients, they start the medicine right away. And if they decide they want to get the shingles vaccine, the typical recommendation per the American College of Rheumatology is to wait a week after your vaccine, and then you can restart your JAK inhibitor. And because the half-life is a couple hours for JAKs, they're out of your system very quickly. But this study actually looked at using tofacitinib, which is a pan-JAK inhibitor, and upadacitinib in a rheumatoid arthritis population. And these patients did not discontinue or temporarily hold their JAK inhibitor at all. They just used it continuously and they got their shingles vaccine and they still were able to mount a satisfactory serological response. So what this data is showing us, at least in a small group of patients, is that you may not necessarily need to stop the JAK. I still do. I just still say wait a week after. What about other infection risks? What becomes clear is that the higher doses of JAK inhibitors do seem to increase the risk, whereas if you look at the lower doses, it actually is comparable to the TNF inhibitors. And the main risk factors for serious infections is what you expect. Older patients, patients who have chronic lung disease, who are on systemic steroids. This is looking at the infection risk now for our atopic dermatitis studies. We're seeing anywhere from 2 to 3 out of every 100 patient years, mostly pneumonia and cellulitis, but quite honestly, this was not much higher than the placebo group. One thing that's interesting though is patients with atopic dermatitis, they are at a higher risk of developing eczema herpeticum independent of the treatment because we know that if your skin barrier is disrupted, you have a higher risk of getting a secondary infection, both with bacteria, but of course with viruses. And because of this theoretical risk of increasing viral infections with JAK inhibitors, maybe we should consider prophylaxing our patients with acyclovir. So this is a nice kind of opinion piece that was written by one of our key opinion leaders in atopic dermatitis. And he made the argument that if you have a history of herpes infections, at least until your skin clears, which is about 4 weeks of the JAK inhibitor, maybe we should be giving patients antivirals to prevent that risk of eczema herpeticum. And I have done that for patients who have a history of cold sores and who have very extensive AED. I'll put them in an antiviral for a couple of weeks. Once their skin clears, I will pull them off of it. And so just common sense for serious infections. How do you risk mitigate? Make sure you check a TB, a Hep B, Hep C, talk about shingles vaccines, try to get the systemic steroids to as low as possible, and ideally just completely off of it. In older patients, it probably is better to use lower doses of JAK inhibitors. And we talked about prophylaxing our patients with antivirals. As far as clotting risk, this is a concern for some of our patients because certain diseases seem to increase your risk above other conditions. So rheumatoid arthritis and inflammatory bowel disease, those diseases have the highest background rate of venous thromboembolisms. And we think potentially it could be due to blocking JAK2, although we're not entirely sure. And what oral surveillance did show is that the lower dose of tofacitinib was comparable to the biologic, but the higher dose of tofacitinib did increase your risk more than the TNF inhibitors. But when you looked at the other pivotal trials for rheumatoid arthritis, it was actually very comparable. The JAKs and methotrexate and adalimumab, and even with our newer JAK inhibitors, the rates seem to be a little bit lower. When you looked at oral surveillance and you really try to figure out which patients were most likely to get a blood clot, it's those patients who already had a history of a blood clot. And that's not a surprise. The hazard ratio here is over 7. But again, patients who are older, people who are taking oral contraceptives, patients who have a history of hypertension, those are the ones that we probably want to be a little bit more worried about. But that said, when you look at the VTE risk, how much of that is due to the drug and how much of it is due to the disease? And what we're looking at here is the rates of blood clots in patients who have various different inflammatory diseases. And what you're seeing is that atopic dermatitis has the lowest risk of a blood clot compared to rheumatoid arthritis and inflammatory bowel disease, which have significantly higher rates. So there is that background rate there. And this is just another study kind of confirming what I just showed you, that there is no significant association between having atopic dermatitis and having a blood clot like we're seeing with rheumatoid arthritis, for example. And this is looking at upadacitinib. This is actually approved for many different indications now. I'm showing you the rates of blood clots across 4 different indications. And the same thing you're seeing here is that the rates, they're low, but they're highest in inflammatory bowel disease, followed by rheumatoid arthritis, then psoriatic arthritis, and finally atopic dermatitis. So there is a disease-specific risk here. And just trying to beat a dead horse, this is a recent systematic review showing you that the rates of VTEs, at least during the placebo-controlled periods, were not very different for JAK inhibitors versus biologics. And here's the rates of VTEs. We're seeing, again, less than 1 out of every 100 patient years, extremely low risks. We're also seeing that there was no exclusion criteria for a prior history of a VTE. In other words, even if you had a clot in the past, you were allowed to come into the studies. And I'm looking at upadacitinib now. Out of the 3 cases of blood clots, 2 of them actually had a prior history of a blood clot. So we don't really know, is it the medicine that's doing it, or is it the fact that they just already had those risk factors and this was going to happen anyways? So these are just some common sense things to be aware of. These are obviously the risks for blood clots. Try to mitigate them as much as we can. Malignancy, we talked a little bit about how this was higher with the JAK inhibitors. Lung cancer and lymphoma were the ones that came up. And this is overrepresented in the rheumatoid arthritis population in general, but we did see this more in older and previous or current smokers. Okay, when you look at non-melanoma skin cancers, we do see a little bit of a higher risk as well. particularly in the rheumatoid arthritis, the ulcerative colitis population, but we really didn't see that with atopic dermatitis. And here's just the malignancy rate. We're seeing still less than 1 out of every 100 patient years. And just be aware that this risk is higher in just rheumatoid arthritis patients in general. Not a bad idea to try to get age-appropriate cancer screening before starting any type of medication, including a biologic, smoking cessation, et cetera. And getting, of course, annual skin exams for people who are considered to be high risk. We're getting close to the end here, but this is just another systematic review looking at JAK inhibitors in atopic dermatitis. And what they concluded was that the risk of herpes zosters, headache, acne, elevated blood CPK, and nausea was significantly increased, but the risk of serious infections, non-melanoma skin cancers, major adverse cardiovascular events, venous thromboembolism, and nasopharyngitis was not increased when you compared it to biologics. And this is, I think, a very compelling paper. This was recently published by Chris Bunick et al., looking at the risk of these adverse events of interest, comparing them to our other systemic immunosuppressants. And what you're looking at here is that these event rates are, with upadacitinib and abrocitinib, are either right in line with methotrexate, if not lower. And when you compare to systemic steroids, which many of our colleagues are using, right, kind of indiscriminately, look at the hazard ratio here. Cancer, MACE events, up to 7 times higher than what we see with our JAK inhibitors. But did anything change in 5 years? Because I showed you 2 to 3 years worth of safety. The main criticism that we get from these systematic reviews is they're short studies, right? We're only looking at maybe 4 to 5 months. This is 5 years now worth of upadacitinib. And the punchline here is nothing has changed. These event rates have stayed flat or they have come down over time. And finally, and I think this is maybe the most helpful slide out of anything we talk related to safety, is that on the top half, we're looking at what I call the 3 C's: cardiac, clot, and cancer. Those are the things I'm actively screening for in any patient I put on the JAK inhibitor. You're seeing the exposure-adjusted incidence rate here. And on the bottom half, we're looking at a real-world kind of database, either coming from the UK, from the US, and Denmark, okay, just to kind of put things into perspective. And of course, this is not a head-to-head study, right? On the top, that's a randomized controlled interventional study. The bottom, this is more of an observational study. But it still is useful because what we're seeing here is that cancers, blood clots, and MACE events, these happen even in people who don't take JAK inhibitors. And when you look at the rates here, we're seeing that it is very much in line with what we're seeing with our JAK inhibitors in a randomized controlled trial setting. And one of the questions I get asked the most is like, well, this patient has this risk factor. I don't know if I feel comfortable putting them on a JAK inhibitor, right? And so there's this perception that maybe we're only using JAK inhibitors in super duper healthy patients. But I just want to give you a little bit more context here. When you're looking at this is the upadacitinib trials, and you look at the percentage of patients who are either a smoker, who had one cardiovascular risk factor, you're seeing many of these patients, right, had those same type of risk factors that we saw in oral surveillance. Half of these patients had one cardiovascular risk factor. Just a third were smokers. 1 in 5 were on a combined oral contraceptive. 1 in 5 were considered to be obese. 15% of these patients would have fit the oral surveillance criteria, and 10 of these patients had a prior history of VTE. So we are certainly not cherry picking patients here. We were taking patients, for the most part, that were kind of very reflective of the general US population. And so where do we go from here? Right? I would say further studies are needed to confirm or refute findings from that oral surveillance study. And we need to call it what it is. Oral surveillance applies to a very specific patient population and is not necessarily reflective of what we're seeing in dermatology. And is it possible that JAK inhibitors may actually be protective against some of these adverse events, then maybe just not as protective as TNF inhibitors? And of course, not all JAK inhibitors are the same. So to conclude here, JAK inhibitors are highly effective therapies. We've seen this with both head-to-head studies with dupilumab, but even in patients who are non-responders to dupilumab. And we're getting a level and depth of response that we have not seen when it comes to skin clearance and itch reduction up until now. Not all JAK inhibitors for inflammatory disease, or excuse me, all JAK inhibitors for immune-mediated inflammatory diseases, including the topical JAK inhibitor, they have the same black box warning that was updated in 2019 from that oral surveillance study. And yes, oral surveillance did show a higher rate of MACE, cancers, and VTEs, but this was in a high-risk rheumatoid arthritis population, which may not be reflective of what we're seeing. And what we do have is both randomized control studies, long-term extension, as well as real-world studies showing that is not corroborating what we've seen with oral surveillance, especially when you look at dermatology patients. We talked about how to utilize risk mitigation strategies to decrease the likelihood of these serious adverse events. So that is going to take me to the very end. If you want to get credit for today's talk, the word of the day is heart. I still have about 10 or so minutes to answer any questions. Thank you all for your kind attention and time.
Well, James, that was a brilliant presentation, tremendous amount of information. Be interested questions from our audience. We had a large number of people still online here. Questions?
And Len, let me just say my email address is here. I'll just kind of put this up here so people can take it down. If they do have any questions or they want to run a patient case by me, I'm more than happy to kind of give my 2 cents and take it for what it's worth. But I probably have several hundred patients on an oral JAK inhibitor for various different indications, not just atopic dermatitis, but some of these other ones that we've talked about as well.
Well, everything that you know and your experience, would you go to this drug first, one of the more selective JAK inhibitors? Do you still try a
Yeah,
monoclonal and see how much benefit you get in, everyday clinical practice?
yeah, that's a great question. And I would say probably the majority of my patients are still going through a monoclonal antibody first. That said, we do have patients that are especially more needlephobic, that are younger, that prefer to just take an oral therapy. So this, both upadacitinib and abrocitinib, they are approved 12 and up. So I have quite a few of my adolescent patients that just we talked about the injections. We even tried it in the office and they just couldn't tolerate it despite what we try to do. So I do have some patients that are just going straight to an oral JAK inhibitor. But per the label, you have to have tried a systemic therapy first. So that doesn't mean you have to have tried dupilumab or tralokinumab. You could have been on a course of systemic steroids or maybe a methotrexate first, and then you can go to a JAK inhibitor. But I would say, by and large, probably the majority of my patients are starting with a monoclonal antibody. It's just that my threshold to switch now is probably a lot lower because prior to the JAK inhibitors, I didn't have many other options. I've had you on dupilumab or tralokinumab for, let's say, 16 to 24 weeks, and you're still not getting a great response. What am I going to do? Sometimes you would dose escalate and maybe start injecting dupilumab every week, right? Or start adding methotrexate or low-dose cyclosporin. But that didn't work for the majority of my non-responders, maybe a small percentage of them. But now because we have the JAKs, my threshold for switching is much, much sooner, I would say, than I have in the past.
Are you saying that these drugs are expensive, I presume, and so to get insurance approval, often
Yeah.
you need to have tried what they consider to be a first-line alternative systemic therapy before you can get insurance to pay the bill?
Yeah, so it's so a couple things. Yeah, these medicines are expensive. They're going to be somewhere in line with the biologics, so they're not cheap medications. And of course, we want insurance to pay for it. Otherwise, the patients aren't going to be able to afford it. Most payers are requiring some type of, actually all payers, they require some type of systemic therapy. It doesn't necessarily have to be dupilumab, though. Like I was saying, it could be a patient's gone intramuscular Kenalog, or they've been on a couple courses of systemic steroids. That does count as a systemic agent per the label. Now, there are some payers that still require dupilumab as a first-line agent before they will pay for either upadacitinib or abrocitinib, but that's purely based on the payer's interpretation. But per the label, you just need to have tried some type of systemic therapy. Now, for patients who have commercial insurance, even if they don't get the drug approved by their payer, they still get the option of going onto a bridge program where they get the medicine for pretty much a nominal cost while the biologic coordinators or the back office are trying to get it approved. I know people have different feelings about going at bridge programs versus not. But, we're in private practice. We utilize bridge programs quite a bit.
Other questions?
Hi, Len. This is
Yeah,
Vinod here.
hi.
Can you hear me?
Yeah, I'll
Hello,
hear
good
you
morning.
fine.
Yeah, great. Thank you, Len, and thank you for a wonderful talk. I had a few questions. I know, in your side effect or the adverse event, most of the
Uh-huh.
data seem to be with the tofacitinib. With respect to the approved AD drugs, when you refer to low dose, high dose, what doses would you consider as low or high, given that the higher dose seems to be more treatment responsive than the low dose is? That's one. The second is, do you immunize with all of your patients of of various ages with the shingles vaccine or other vaccines, or is there a certain protocol you follow there? And third would be monitoring. I mean, in terms of how do you monitor your patients, or what routine do you do for your patients in terms of surveillance? Thank you.
Yeah, three very good questions. So let me start with the vaccination question. So I kind of alluded to this before, but shingles is certainly a signal for our JAK inhibitors. And as you know, if you're 18 and older, you can get the shingles vaccine if you're on some type of immunosuppressant or immunomodulator. My personal practice is that I always talk about it. And generally, the older the patient is getting, the more I'm going to push them to get the shingles vaccine. I don't require it necessarily, but I always do at least offer it to them. As far as how to time the vaccine, though, I was just saying earlier that I don't wait for them to get both doses. I think having a patient wait and suffer from their atopic dermatitis for several months to get both doses of the shingles vaccine is just too long. So I will have them start the medication right away, the JAK inhibitor, and whenever they're ready to get their shingles vaccine, they'll just stop it a couple days before, and they'll hold it for a week after the shingles vaccine, and then they could restart it. That said, this particular slide here kind of asked the question as to even if you don't stop your JAK inhibitor, can you still mount a sufficient response? And at least based on this small group of patients, this wasn't hundreds of patients, it does seem like you could still develop a pretty good response even without stopping it. But I think what most people are doing are stopping it for a week after they get the dose. You also asked about monitoring. So the labs are pretty much what I would order for. Well, I'm not sure what you guys normally order for your biologics. I know you don't order much for dupilumab, but CBC, you want to make sure there's no baseline cytopenia because it's rare, but sometimes you'll see a change in the neutrophils or the lymphocytes as well as the hemoglobin. So you want to check a CBC, check a CMP, right? So we want to look at the liver and the kidney in particular. In patients who have chronic kidney disease, so if their GFR is under 60 but still over 30, we actually have to cut the dose in half. So we'll use a lower dose, and then we could kind of go up a little bit more. But you do have to make a dose modification there based on their kidney function. In patients with liver disease, as long as you don't have frank cirrhosis, so you're not like a child pube class C, there's no contraindication to use these in people who have like a little fatty liver. That's not an issue. I'll check a Hep B, Hep C, and Quant Gold just because there is a potential for reactivation. And then we check a fasting lipid panel at baseline too. I know I didn't show you the lab parameter changes, but we do see a little bit bump of the LDL levels. But what's interesting is that the HDL goes up a little bit too, so we're not sure how real that is. So we'll check that at baseline. And then generally anywhere from 4 to 12 weeks after starting the JAK inhibitor, we'll check a CBC, a CMP, and a fasting lipid panel again. Okay, and I'll do that anytime I dose escalates. If I go from a lower dose to a higher dose, then I'll check it again. After that, I probably check it every 3 to 6 months. So I have several patients that have been on the drug for 2+ years. I'm checking their labs maybe every 3 to 6 months at most. That's a CBC, CMP, fasting lipid panel. Based on the data that we have, if you are going to get a lab change, it typically happens within the first 12 weeks. But really, I have not seen much, maybe a little bit of lipid elevation. That's probably the thing that I've seen the most. And then I think you asked about the 2 different doses. Okay, so both those are even the lower doses of the medications, they actually work quite well. And I have very few patients that need the higher dose. Sometimes I will temporarily kind of give them a higher dose and then drop it down to the lower dose if possible. From a safety standpoint, there are certain adverse events that we do seem to see more with the higher dose. That includes acne, which I know probably isn't the biggest deal, but some of the lab changes we do see with the higher doses as well. But just in my personal practice, I have not needed to use it for much more than maybe a couple of weeks or months, and then we could drop them back down to the lower dose. And actually, so upadacitinib has a 15 and a 30 milligram dose. Abrocitinib has a 100 and a 200 milligram dose. Per the label, you have to start patients on the lower dose first. So even in the clinical studies, there were patients that went straight to the higher dose. Per the label, everyone starts on the lower dose. And then after a certain amount of time, which is usually around 4 to 8 weeks, because that's really when you're going to know if that patient's responding to the medication or not, then you can dose escalate.
Thank you so much. And
yeah,
thank you. It's 8 o'clock. Probably most of our folks need to drop off, but I thank you really for a brilliant talk, educating our community, as I said right at the beginning, and as I think the allergy community has been sluggish and reluctant to use these drugs. I think you made a convincing argument to educate us that we're underutilizing them, maybe to the detriment of our patients. So thank you so much.
It was my pleasure, and I thank you guys for really the opportunity. It really was a privilege. Thank you so much.